joined today by two excellent speakers, Jason Banks, Vice President of Business Development at Invoke, who will discuss how documentation quality and clinician-friendly technology can reduce denials before they ever reach the billing stage. Ashley Waller, VP of Revenue Cycle Management at HealthRev Partners, who will share her expertise on denial prevention and revenue cycle management strategies. Together, they'll show how upstream documentation integrity and downstream revenue cycle management work hand in hand to reduce denials and strengthen your agency's financial health. So with that, I'll hand it over to Jason and Ashley to get us started.
Hi, good afternoon.
Hello, thank you, Andrea. Thank you so much. And Ashley, do you want to sort of kick us off why denial management matters to organizations now?
Yes, absolutely. So as we all know, denials are rising across home health and hospice with the claims. Claims are rising, but denials are increasing across home health and hospice. And that just has lost revenue, lost time for your staff and your agency. And we're just going to talk through some of those details and how we can be proactive and act proactively as an agency to prevent that.
Awesome. Thanks, Ashley. And just to add some color to that, sort of the initial claim denials hit about 11, almost 12% in 2024, which was up from just over 10% a few years earlier. And a big part of that, a big chunk of that, which I'm sure you all are seeing and will address today, is the commercial and the Medicare Advantage plans. They're a huge factor. Just to give you an example of that, denials from commercial plans rose 1.5%, and Medicare Advantage plans saw almost a 5% spike from 2023 to 2024 in claims denials. And you can think of the RCM process or the revenue cycle process as sort of a chain from eligibility to authorization, documentation, good coding. If any link of that chain is weak, denials will happen and your cash flow will slow. And all agencies know that billing starts the moment you get a referral. And downstream RCM teams have fewer gaps to fix. Really, billing should not be a cleanup area for incomplete or inaccurate documentation. It's like giving your billing team a clean runway instead of something that's full of potholes. And in order to do that, you need to have the right people, process, technology partners that support that.
Yes, yeah. So the true cost of denials, at HealthRev, we did a study and we found that 20% of claims will deny initially. And then 60% of those claims may never be resubmitted. And the average amount it takes to rework one claim would be $25 to $117 per claim. So to put that into a little bit more perspective, for an agency submitting 5,000 claims monthly, that could be 1,000 claims could be denied initially. And that rework cost on a monthly scale would be $25,000 to $117,000 a month. That's a lot for an agency to lose out on in just a rework of a denial. So an annual rework expense could possibly reach $300,000 to $1.4 million in a year. So, that's something to really consider whenever you're trying to grow an agency or hire more staff. So, lost time that it's for the staff to rework those claims, pulling those resources, and then it's also taking away from that patient care and the agency's growth.
Awesome. And when you look at the top reasons, at least the top 5 causes of denials, so many tie back to documentation. In hospice, specifically around medical necessity and CTIs, CGS, which many of you know, one of the Medicare MACs, reported that from July to September of 2022, 59% of claims reviewed did not support a hospice prognosis of 6 months or less, and 29% of the claims were denied due to related Medicare benefit election statement requirements not meeting the documentation, not meeting those requirements. And those findings are similar for NGS and Palmetto. And this is where Envoke helps. Clinicians can really capture complete compliant documentation in real time, reducing that chance of downstream rejection. I've seen agencies, spend, to Ashley's point, hours and hours on rework for missed detail that could have been solved with a clear note. In addition, CGS reported during the same time period that 43% of claims reviewed did not support medical necessity for nursing or therapy services in home health, and that 45% of the claims denied were related to certification or plan of care requirements that were not being met, including face-to-face encounter denials. And again, those results are similar for NGS and Palmetto as well. Anything to add there, Ashley?
Yeah, so and what we kind of see, we see these eligibility authorization errors, so we have to rework those many times. It's incorrect benefit checks or missed prior authorization for a specific payer. Then we also see the missed deadlines and backlog submissions, so it's late or no NOAs. And then just hitting those timely filing. Maybe they were missed timely filing deadlines that, we come across. Another denial reason could be coding or OASIS mismatches, incorrect primary diagnosis in there, or inconsistency between the OASIS assessment and then what we've built out. So those are things that we're looking at, reworking those denials and trying to fix that on the front end. And then lastly, just a lack of a structural denial review process. Just really a centralized RCM management process that could result, if you have that, it would help to fix those repetitive and preventable errors on the front end and not have to rework that and lose the money that the agency is trying to get for their revenue.
Absolutely. So how do we go prevent those denials upstream? So the first line of defense obviously is making sure that there's quality documentation at the point of care. If what the clinician captures doesn't fully support the visit, it's going to create that downstream rework, delays, denials. All of those things are going to cost the agency money. Then you're going to also need stronger narratives. Payers need to see not just that the visit happened, but why it was necessary and why future visits are necessary. Narratives that are going to clearly establish medical necessity in hospice, specifically around CTIs, plans of cares. They'll dramatically cut the denial risk. Think of it as telling the story of the patient instead of just checking boxes. And then you want to have clinician-friendly tools. So when the tools are easy to use, clinicians will adopt them, and the adoption will drive compliance. If it takes the clinician extra clicks, slows them down, then documentation will get skipped, delayed, rushed, which will obviously come back in denials. Our focus is really on clinician-first design, making it faster, simpler, and integrated into their normal workflow seamlessly. And then that results obviously in proven results. We've seen real improvements, not just in home health, but in hospice, in CTIs and plan of cares, documentation that is typically causes clinicians a lot of headaches, as well as agencies on things like audits are now being consistently completed and compliant. Agencies are reporting to us fewer rework loops and then faster turnaround and measurable reduction in denials, which is actually improving things like their DSO. And the agencies are telling us as well, it's not, and we're going to share some of the results that both Ashley at HealthRev Partners and I at Envoke are seeing out there in terms of measurable numbers. But agencies are also telling us that it's not good enough to have a point, tool that works for one clinician or one type of visit. It has to work everywhere for everyone. That means that it's got to work with any EHR operating system, device type, clinician role, visit type, and it must also be secure, accurate, and compliant. And the organization, the vendor partner that they work with, those are table stakes. And if they don't have those things, then adoption is going to fall. And preventing those denials as upstream as possible isn't fixed. The clinician where they are, supporting them with better tools, ensuring the outputs flow cleanly into every system downstream. There's so many things that go into this, from clinician productivity to the EMR that you're using, that it really is important that you pick the right partner as you look at solving for some of these problems. I've lost her. Okay. Well, part of this also, and something that HealthRev Partners is really good at. Hi, Ashley. We lost you there for a second.
Hi.
Hi. Welcome back.
It happened.
Oh, good. You joined just at the right time. So this is this is your and HealthRev Partners wheel, which is strengthening that downstream denominator.
Yeah. So we want to do the rapid review, use the denial data to fix the root cause in those workflows, and really focus in on the trends we're seeing. Establish a playbook, assign that responsibility, and just put those strategies for each payer so that you can get that root cause. Those patterns, but make sure that the loop, and we see that to intake, coding, clinicians, just so that we can prevent those repeatable mistakes. And then also just using KPIs to make sure that we're doing due diligence to turn over that denial appeal, have a successful appeal rate, and making sure that we're getting those KPIs and those claims work in a timely manner.
Right. And I know education is part of that sort of feedback loop that you all create. And one of the things that we're seeing is and organizations really want to focus on this sort of end-to-end framework, a complete cycle to stop the denials, because again, every one of the processes, both clinically and from the off perspective, are interlocked with one another. So when we talk about, one of the most effective denial prevention occurs before the visit even starts, by verifying eligibility, authorizations up front. Agencies can stop those denials before they ever hit the system. And it's also a lot of these tools that will summarize some of that information for the clinician is going to save that clinician wasted time, that'll protect their scheduling capacity, and it's going to ultimately reduce the rework that they have to do. And then when you talk about documentation quality, it's got to be accurate. It's got to be complete. Many clinicians, whether it's 30 units per week or 25 units per week, they are really sort of well-oiled machines that are out there, and I say that in a good way because they're doing really compassionate care, but they're held to these productivity standards. And so we want to give them the tools to be as accurate and complete and well-structured in their documentation as possible to support medical eligibility, speed up the payer approval process, and it's clear from the start, they're far less likely to kick it back. And also, when you face an ADR or you face a SMRC audit or TP&E audit, you're less likely to get those clawbacks that many agencies are seeing. Ashley, do you want to talk about denial monitoring?
Yeah. So, Waystar has denial monitoring and making sure that you're tracking, categorizing, and resolving denials as soon as you're billing those out, getting that resolution. A lot of the different clearinghouses have this now to where that you can really online and make sure that you're getting claim out. And then to get it in a clean manner up front, like Jason said a slide or two ago, and make sure you're educating across the board to reduce those reoccurring errors. And then you're also going to want to do monthly denials and continual improvement.
Agreed. I think the point is there's no single team within an agency to solve this on. It takes intake, it takes clinical QA, billing, education. They all have a hand in the process. That's why it's so helpful to have partners like HealthRev Partners who understand the end-to-end process and can operationalize solutions across all the stakeholders within the organization. And it's about providing capabilities that match where you are, but having tell us about some of the results.
Yeah. So this is just in May 25, one of our home health and hospice agencies came to us with 227 claims in the 121 plus bucket, which means 121 days outstanding forward. So some of those were sitting, in the 400 days outstanding, 500. It was a lot of claims that were totaling over 479,000. HealthRev conducted a root cause analysis and created an action plan to get the claims paid. We're currently at 87 claims left, and actually, just since this PowerPoint, we went down to 78. So, that's $287,000 that have been paid just by conducting that root cause analysis, creating the action plan, and going through that denial monitoring process and trying to put those processes in place to get those errors from reoccurring over time. The remaining are due to medical record reviews and sequential billing process, and they're actually expected to be paid. So, that's a huge win for that agency. The same agency, there were 30 RTP claims with the same root cause analysis and action plan. We've gotten that down to 0, and it is maintaining that same amount on a weekly basis at 0.
That is fantastic. I'm sure they're thrilled. Let's talk a little bit about Amedisys. They're obviously one of the largest home health and hospice providers across the country. Like many agencies, they were experiencing denials tied to documentation. In this case, specifically, their hospice CTIs, payers were flagging some of those big or big medical necessity, and for them that meant a lot of ultimately delayed or denied payment. And and really told us the problem that they were having. And not them using a solution, but actually helping us to develop a solution for them. What they wanted to do was improve the documentation quality without adding additional physician workload. And by using Envoke, they saw significant gains in the richness of their narrative, so the length of their narrative. It became 42% longer, and it has state PPS scores, clear evidence of disease progression, and in just 9 months, their documentation error rate dropped from 15% down to 3%. And what's equally important, if not more important, is the clinician experience with that. Physicians cut their documentation time by 50%, and they reported higher job satisfaction and even described a better work-life balance. And while the study, really focuses on hospice, there are, takeaways from this that apply to home health as well. When you have documentation that clearly supports medical necessity, whether it's in CT, in subsequent visits, or your art cares, or even home health in your OASIS assessments or the plan of cares, you really strengthen compliance, reduce denials, and ultimately protect thing at Covenant Health. A great and an example of how improving the document truly has for users. Clinicians were spending a lot of time on the tablets documenting, often finishing that documentation after hours. That led to delays, some burnout, documentation of delay. And so we know that that's agencies at risk for compliance issues. And after implementing this was clinician first focused, they saw really dramatic improvements. 85 words per minute. And to give you an example, typing on a tablet, typing home health notes is typically 35 to 40 words per minute. And so they're completing more visit notes in the home instead of after hours. And with the quality analysis, they're providing real-time quality checks of their documentation, so that the documentation is audit ready, it's defensible. And what's really powerful here is that the impact wasn't just about efficiency. It touched, again, all areas of the organization: compliance, retention, revenue protection. When documentation is more accurate and it's timely, agencies will reduce their denial risk and ultimately strengthen their bottom line, which is super important because we know that every reimbursement dollar is sacred, while also giving their clinicians better work-life balance, reducing their stress, their workload, and ultimately preserving those clinicians.
Yeah, that's amazing. I bet that really helps with the turnover rate.
Absolutely. I mean, it's one of the largest. I know there was a study that we looked at several years ago, but I think it's only probably exacerbated since then, that looked at the number one reason for clinician work-life balance and the turnover of those. And this was specific to home health, which there's not been many studies for. And the overwhelming majority of them were documentation. The documentation burden is driving these clinicians to look at other 9 to 5 jobs. And we know, and many of you know on this call, that nurses, PTs, they have so many options, right? They are in high demand. They can go to, 4 walls. They can go to SNFs. They can go to hospitals. They can go to physician offices. and they can work 9 to 5 and punch in and out. One of the reasons, and many of the reasons that many clinicians get into home health has to do with the flexibility, and they also enjoy the relationship aspect of care. They're not as transactional, but really a lot of them get into it because of the flexibility. And with the regulatory environment as it is, it's driven a lot of that flexibility out of that workload. And because they have such this heavy burden of documentation. And so it's really important at Envoke for us to be able to work with our customers to solve for that.
Yeah. Yeah. So I just wanted to touch on denials are very costly. So these are just some of these takeaways that denial prevention is a team effort. Like we've been saying, it takes the whole process. It takes intake, clinical, billing, the RCM staff. And the cost of denials is both financial with lost revenue, and it's an operationally. So it's the staff and the turnover. And then it also, it addresses the issue. You want to address them both upstream and downstream.
Absolutely. And as we've been talking all along, the solutions that you employ with your vendor partners really should be focused on, how do we strengthen the documentation process, improve those eligibility checks, and really build a structured denial response process. So with that, I'm going to turn it back over to Andrea to land us here, and then we're going to open it up to question and answer. I see some people have put some in the chat already, but if you have any, feel free to ask those. And with that, Andrea, do you want to take it from here?
Absolutely. I'll help guide the Q&A session here. Yeah, Jason, Ashley, thank you so much. This is really great information, super helpful for people. So if you haven't already, I see there are some popping in, but please type your questions into the Q&A or the chat. We'll get to as many as we can with the time we have left. And really, you know what, this is your opportunity to ask about specific denial challenges you're facing or to get any clarification on any of the strategies we covered today. So with that, I'll go check our chat here. Looks like this is a long one. I'll read this over to you guys. We entered a probe and educate due to giving more visits than our competitor. They, of course, did not do and were not skilled enough. Needed. Then we waited for the education part, and then when we did the challenge, it was past the date. Is there any recourse to this, and just to let other agencies be aware not to wait? Yeah, that one's a little in depth. Do you guys want to kind of break that apart a little bit, or?
Yeah, well, I will say that TP audits are on the rise. And, I think if you look at audits, one of the things that they look for is a deficiency in care plan goals and interventions. And it's one of the areas that clinicians really struggle with the most in terms of defensible documentation. And, first of all, I can't help but sort of laugh that, and not in a serious way, in a really frustrated way, that you're getting dinged on having too many visits associated with your episode of care with your patients. Anyway, I'll save my commentary there. But I think it's sort of silly, not on your side, but on the auditor's side, that they're concerned about that. I think where we try to help in terms of documenting these things is to give, what we do is we give the clinician in real time sort of a way to document that is much more defensible, and that even when it comes to care plans, making sure that we're providing the clinician with real-time suggestions on what to put in the documentation that will pass muster as it relates to audits, pass muster as it relates to claims submittal. And here, I'll give you one example. There are multiple ways to phrase things, but if you're in a hospice environment, you might say that patient has no pain versus if not for the interventions that our IDG team is providing, patient's pain would exacerbate, right? So there's ways of phrasing things in the documentation that will provide you more defensibility in that documentation. And so, you can probably find the right partners out there, and Voke's happy to help you with that and sort of dig in, because we know that not just Target, Probe, and Educate, but also many of these other audits are causing so much disruption to the business and ultimately costing them a ton of money that they simply can't afford. Ashley, I don't know if you want to add anything to that.
Yeah, I mean, I think, just in of course, the documentation, and then just making sure you're responding to that. Even maybe before the education, waiting on the education, go ahead and responding to it so you can get that claim work going. But yeah, I think, just the tools that Invoke uses, would really benefit in cases like this.
Okay. Yes, good. One other one, if you could implement one operational suggestion to decrease denials, what would that be?
So I'll take that one. I think that just to decrease denials in operations just up front, really focusing in and looking at those eligibility verifications, and then making sure that you're doing kind of like a pre-bill check up front to make sure that those claims have all the necessary information on it, and make sure that you don't need to go back and loop in another department that could help you before you get that claim sent out. And then just making sure that whenever you see those denials, you're training those out and really closing that loop, and making sure that everyone on the team is educated to prevent those denials. But definitely doing a really thorough pre-bill check up front.
Okay. Yeah, and we've talked quite a bit about, the types of denials. Are there, what are the top 3, would you say, that you're seeing most in the industry?
So definitely eligibility authorization. That would probably be the number one. And then coding and OASIS would be a second one. And then the third would be more of like claim formatting issues, to where you're reviewing your claim, that those things are input into your EMR, and making sure